Good evening, everyone. This is the last session in the second day of the meeting and very important session, which is the Pan-Arab Heart Failure Summit. I have the pleasure to co-chair this session with my dear friend, Professor Ayman Saleh. He's the Vice President of Ain Shams University, Professor of Cardiology, and a well-known expert in intervention, the heart failure in Egypt, and one of the eminent professors. So I'd like to thank him very much for accepting the invitation and coming today. Welcome, Professor Ayman. I have the pleasure also that we have chairpersons in this session. My dear friend, Professor Amr Zaki, Chairman of Cardiology at Alexandria, Cardiology Department at Alexandria University. Professor Ahmed Magdi, Professor of Cardiology, National Heart Institute, and the co-chairman of the Working Group of Intervention. Allow me to welcome our guest faculty from the Arab region, Professor Abdullah Shihab, Professor Abdul Majid Zubayd, Professor Hadi Skouri, Professor Hadi Abu Hantash, Professor Layla Abid. Professor Abdullah Shihab, we know is a dear friend for all of us. Professor Abdullah is the immediate past president of Emirates Society of Cardiology. He's an intervention cardiologist, General Secretary of Emirates Cardiac Society, Vice President of the Gulf Interventional Society, and the Editor-in-Chief for the new Emirates Medical Journal. Welcome, Professor Abdullah. Professor Abdul Majid Zubayd, he's current President of Emirates Cardiac Society. He's the chair of Cardiac Sciences, Sheikh Khalifa Medical City, medical advisor at the Ministry of Presidential Affairs. Welcome, Professor Abdul Majid. We did before such session Pan-Arab maybe 2 months ago with my dear friend Professor Firas Badr. He apologized to attend this meeting today. So I'd like to thank Professor Hadi Abu Hantash, Professor Hadi Skouri, Professor Layla Abid, Professor Khaldoun Al-Hamoud, who are the distinguished speakers for this session. And I'm sure that this session will be an interactive one because the titles of presentations are very interesting for all of us. So I encourage all of you to actively participate. And with us, Professor Amr Zaki, Professor Ahmed Magdi will join the discussion. So now Professor Ayman Saleh can introduce the first speaker in this meeting.
Thank you, Dr. Magdi. Good evening, everyone. كل سنة طيبين بمناسبة المولد النبوي، واحنا سعداء بوجود الزملاء الأشقاء من كل الدول العربية والزملاء من مصر. في تعديل طفيف بس ان الدكتور هادي سكوري طلب ان هو يعني يبقى second speaker، فاحنا بندعو الدكتورة ليلى عبيد، Professor of Cardiology, University of Sfax, and the founder and coordinator of the research unit, coordinator of heart failure, Tunisian registry, Nature Heart Failure, and the president of the Tunisian Society of Cardiology and Cardiac Surgery. بندعوها انها تبدا هذه السيشن يعني مع تغيير طفيف بس، موضوع في غايه الاهميه، management of heart failure during pregnancy. اتفضلي دكتوره ليلى.
Thank you very much. Well, first of all, I'd like to thank the Egyptian Society of Cardiology and special Professor Magdi Abdel Hamid for this invitation. And I thank him for this quality of meeting, with this wonderful meeting. We are accustomed with the dynamism and the passion of our friend Professor Magdi Abdel Hamid. I'm very happy also and delighted to share this session with my colleagues from Middle East. And I will talk about the management of heart failure during a pregnancy. If you look to epidemiology, what are the major causes of maternal death? We find that maternal heart disease is the major cause of maternal death during pregnancy. And if you look the causes of this heart disease in the pregnancy, we find especially based to this study in South Africa that we find peripartum cardiomyopathy in the first one, and the second one we find rheumatic heart disease. In the Western countries, in the first we find rheumatic heart disease, and second one we find peripartum cardiomyopathy. But we, as you see here, the causes are dominated by peripartum cardiomyopathy. And if we look for the major causes of heart failure, hospitalization based to a registry of pregnancy and cardiac disease, ROPAC registry of the European Society of Cardiology, we find that in more than 70%, the cause of hospitalization is left heart disease. It can be valvular heart disease or cardiomyopathy. And based on the epidemiological study, the global mortality increases with the maternal age. The more the pregnant woman is aged, the more she is at high risk of mortality. So why pregnant women are at risk to develop heart failure? To answer to this question, we need to look to the physiological adaptation to pregnancy. In fact, pregnancy induces changes in the cardiovascular system to meet the increased metabolic demands of the mother and fetus. And the plasma volume and cardiac output reach a maximum of 40–50% above baseline at 32 weeks of gestation, while 75% of the increase has occurred by the end of the first trimester. The increase in cardiac output is achieved by an increase in systemic volume in the first half of pregnancy and a gradual increase in heart failure thereafter. In women with heart disease, left ventricle and right ventricle adaptation to pregnancy can be suboptimal, and maternal cardiac dysfunction is related to impaired arterial flow and suboptimal fatal outcome. There is also a systemic and pulmonary vascular resistance decrease during pregnancy, it's about 20%. So, besides all this mechanism, pregnancy is a hypercoagulable state associated with increased risk of thromboembolism. And in some cases, with fever, infection, sepsis, anemia, anesthesia, hemorrhage may increase the cardiovascular stress, and so the risk to develop cardiac heart failure. And so this curve shows the physiological change occurring during pregnancy with the increase of plasma volume, heart rate, and the cardiac output and stroke volume. And the periods of increased cardiac output are especially between 28 and 32 weeks gestation, in labor and delivery, and immediately postpartum. So in this period, pregnant woman is very vulnerable. So what are the signs of heart failure? When should we think to heart failure in pregnant women? There are common signs such as dyspnea, cough, asthenia, odynia of the lower lungs, orthopnea, palpitation, dizziness. But we can also find less common signs such as nocturia, right hypochondrial pain, chest pain, orthostatic hypotension, and syncope. And so we can have minor to severe symptoms. It's characterized also by variable presentation, and often these signs are ignored by the patients, but also by nurses and the doctors. So there is an algorithm that helps us to diagnose heart failure in a pregnant woman, in case of dyspnea, in pregnancy or postpartum, we should, based on the history, and we should conduct a clinical exam, and we should, based on also electrocardiogram, BMP, and echocardiography. So if there are abnormalities, the patient should be referred to cardiologist. But if all the exam and the ECG, BMP, echocardiography are normal, so we must think to another cardiovascular dose. So what are the causes of heart failure that explain heart failure in pregnant women? There are many etiologies such as peripartum cardiomyopathy. There is also pre-existing cardiomyopathy dilation or valvular heart disease or congenital heart disease, pregnancy associated to myocardial infarction, pulmonary embolism, myocarditis. So it's very important to base on history, biomarkers, echocardiography, and sometimes we need official tests to have the diagnosis, especially if the pregnant woman isn't filled for heart failure, a case of heart failure. And I will focus on peripartum cardiomyopathy. And there is a new review published in 2020, the peripartum cardiomyopathy in the Journal of American Cardiac Cardiology. And there is another paper published in 2018 about by the European Society of Cardiology about peripartum cardiomyopathy. And the definition of peripartum cardiomyopathy is it's a heart failure due to non-ischemic cardiomyopathy with reduced ejection fraction less than 35%, and commonly presents in the first months postpartum or towards the end of pregnancy. And it's the same definition proposed by the European Society of Cardiology, especially the Heart Failure Association. The peripartum cardiomyopathy is an idiopathic form of cardiomyopathy presenting with heart failure secondary to left ventricular dysfunction toward the end of pregnancy or in the months following delivery where there is no other causes of heart failure. So I'd like to focus that cardiomyopathy can occur in pregnancy, but also on postpartum. It doesn't occur only on postpartum. What are the patients who are at risk to develop peripartum cardiomyopathy? We find African American race, preeclampsia, hypertension, multi-gestational pregnancy, and the age of more than 30 years. And if we look to the incidence of peripartum cardiomyopathy, this incidence differs from a region to another, and reports show that it's higher, for example, in Haiti. It's about 1 in 300 deliveries in Haiti, and it's lower in Japan. It's about one patient between 20,000 patients. So the incidence isn't very, the true incidence is unknown, but it's very variable. And how should we diagnose the peripartum cardiomyopathy? The echocardiography is the exam of choice to diagnose peripartum cardiomyopathy with ventricular dilation, but rarely we find no dilation of the left ventricle, global hypokinesis, myocardium theme, functional mitral regurgitation, and we can find the intraventricular thrombus, and we can have a reduction of left ventricle ejection fraction, but it could be normal. And the speckle tract is very, very interesting to detect, especially the intraclinical cases of peripartum cardiomyopathy like this, and it will be decreased. And there are described the cases of peripartum cardiomyopathy without reduction of left ventricle ejection, with normal ejection fraction. We have only a decrease of diastolic heart failure, and longitudinal systolic strain is very, very interesting to help us to have the diagnosis of peripartum cardiomyopathy, because it will be reduced and it helps us to detect the subclinical form of peripartum cardiomyopathy, and it was proposed in this paper cutoff of 10% to detect this subclinical peripartum cardiomyopathy. So it's very interesting to detect earlier this diagnosis and to treat the pregnant woman early. What are so the risk for these patients who have peripartum cardiomyopathy? There is the risk of sudden death, and the mortality ranges between 5 to 50% at 3 months, and the recovery is also about 50% at 3 months, and it will be a partial recovery, which is about 20 to 30%, and the risk is the relapse. The relapse is about 50%, and we find also even 100 in some papers. So how should we treat heart failure and peripartum cardiomyopathy in pregnant women? The treatment is there are many particularities of the treatment, because we should focus on the maternal risk, but also for the fetus risk. And we are based on the guidelines of the European Society of Cardiology about the management of cardiovascular disease during pregnancy. And if we look to these guidelines, normally if a woman has a left ventricular ejection fraction lower than 30%, and especially if she is symptomatic with any HA-free water, the pregnancy is contraindicated, is a contraindication for the pregnancy. And in this recommendation, we find a classification of the risk of the patient who have a cardiac disease. If we look here, for the patient who have severe dysfunction with left ventricular ejection fraction lower than 30%, or between 40 and 45%, or even more than 45%, they are classified as World Health Organization 2, 3, and even 4. So patients with heart failure are considered at high risk of mortality and cardiovascular complication. So if we look also to this recommendation, we need a pregnancy heart team in this case. The minimum team requirement are a cardiologist, an obstetricians, and anesthesists, all with expertise in the management of high-risk pregnancies in women with heart diseases. So we should have a multidisciplinary treatment and management of these patients. So the question is, would we use the same treatment that we are accustomed to use when we are treating patients with heart failure, and you are accustomed with this algorithm proposed by the European Society of Cardiology? Would you use ACE inhibitors and beta blockers? Would you use MR antagonists and the others treatment? So what are the medical treatment of heart failure in peripartum? Especially, we should have in mind that we can have a fetus effect in pregnancy, also we'll see in postpartum. So to answer this question, I'm based on the recent paper published in the American College of Cardiology journal about the treatment of peripartum cardiomyopathy. And as you see here in the table, we have all the medication treatment of heart failure. So in case of pregnancy, you can use loop diuretics, beta blockers, fibrillazine nitrates, digoxin. But we should take caution about potential adverse effects, especially for hypovolemia for loop diuretics and hypotension for hydralazine nitrates. And they have the same indication for the patient who have heart failure, that during lactate, also we can use all these treatment, loop diuretic, beta blockers, hydralazine nitrates, and digoxin. And I want to focus on the fact that when we have drugs with green color, that means that data are experienced to encourage to prescribe this treatment for a pregnancy woman. When it is red ocean with using these drugs, and what it's blue, data is limited or insufficient to use this drug. So, can we use ECU inhibitor ARB, aldosterone receptor antagonist, sacubitril valsartan, and ivabradine? The answer is no for patients because we haven't enough study, enough arguments to prescribe them for pregnant women, and also because they have potential other adverse effects such on fetus, especially for ACE inhibitor ARB, for spironolactone also, and the same thing for sacubitril, valsartan, and ivabradine. But if we look for lactation, we can use ACE inhibitor, and especially enalapril and captopril. We can use also spironolactone, but we haven't enough information for sacubitril, valsartan, and ivabradine. If we look to the anticoagulation, we know that patients who have heart failure, especially severe heart failure, are at risk of developing thromboembolic events. And so, what are the anticoagulants that can use in a pregnant woman? Low molecular weight heparin can be used safely even during pregnancy or during lactation, but we should avoid warfarin, especially during pregnancy, but it can be used during lactation. So it's very important for the treatment for pregnant women, and I'd like to precise that for women who have peripartum cardiomyopathy, anticoagulation should be prescribed, especially when we have left ventricle thrombus, and if we have severe left ventricle dysfunction with left ventricle ejection fraction less than 35%. What are the outcomes of these patients? The worst prognosis is related to the lower left ventricle ejection fraction, the dilated left ventricle, the African American race, and the delayed diagnosis. And what about the long-term outcomes? For the long-term outcomes, after recovery or duration of medication treatment is unknown, but it's recommended about the treatment of 6 months. In the case of stopping medication, wean gradually and observe closely. We should follow our patients regularly, and we should continue surveillance after recovery. So, a pregnant woman who had peripartum cardiomyopathy, if she like to reconduct another pregnancy, subsequent pregnancy, it depends on the left ventricle ejection fraction. If she fully recovered, normally there isn't a great risk, but if there is a poorly recovered left ventricle fraction under less than 50%, so it needs specific management, and it needs follow-up, strict follow-up for these patients, and respect both the treatment, what means bromocriptine, oral heart failure, anticoagulation, relaxant vasodilator, and diuretics. So it's the same thing for the guidelines of the European Society of Cardiology dealing with the treatment of heart failure during pregnancy, and they propose for us algorithm for the treatment of acute, subacute, because I talked about chronic heart failure when the patient is stable, but what is about the acute and subacute heart failure, and especially when we have a cardiogenic shown. Guidelines apply for rapid diagnosis and decision-making, specified management algorithm and expert and interdisciplinary team are crucial, very, very important, and they recommend induction of lung maturation, and after that it depends on the status and prognosis of the fetus. If the fetus is not viable, they recommend delivery. If the fetus is viable, it depends on parent switch, material, and fetal status. It's very so important. But if the patient is in a cardiogenic shock or dependent on inotropes or vasopressors, she should be transferred early to a facilitator where mechanical circulating support teams are available, and urgent delivery by cesarean section, irrespective of gestation, should be considered with mechanical support circulating immediately available. And peripartum cardiomyopathy patients are sensitive to the toxic effects of beta-adrenergic agonists, which should be avoided whenever possible. But levothyroxine down may be the preferred inotrope. But in the other case, if the patient is stable, stabilized heart failure, management goals are similar to now pregnant acute heart failure by avoiding phytotoxic agents such as ACE inhibitors, ARB, IRNE, MRA, and atenolol. Heart failure, so with pulmonary congestion, is treated with local diuretics, and however, diuretics should be avoided in the absence of pulmonary congestion due to the potential reduction in placental blood flow. So hydralazine and nitrates appear safe in pregnancy, although with less evidence for benefit than ACE inhibitors, and should only be used in presence of hypertension, severe left ventricular dysfunction, and or evidence of congestion in decompensated heart failure. For beta blocker should be initiated cautiously and gradually uptitrated to the maximum tolerated dose. And I would like to talk about bromocriptine treatment, which will be accompanied by also prophylactic anticoagulation. But bromocriptine treatment in class 2A and level of evidence C is recommended to prescribe it to in case of peripartum cardiomyopathy, and its addition to standard heart failure treatment may improve left ventricular recovery and clinical outcome in women with acute severe peripartum cardiomyopathy. Bromocriptine 2.5 milligram once daily for at least 1 week in a complicated case, whereas prolonged treatment 2.5 milligram twice daily for 2 weeks, then 2.5 milligram once daily for 3 weeks may be considered in patients with left ventricle ejection fraction lower than 25% and or are in cardiogenic shock. So the other question that we should ask behind these patients, pregnant patients, which are at risk of sudden cardiac death, especially with peripartum cardiomyopathy, should we implant a defibrillator to prevent sudden death? And given the high rate of improvement of left ventricular function during optimal heart failure during therapy, the early implantation of an implantable cardioverter defibrillator in patients with a newly diagnosed peripartum cardiomyopathy or dilated cardiomyopathy is not appropriate. A wearable cardioverter defibrillator may prevent sudden cardiac death during the first 3-6 months after diagnosis, especially in patients with ejection fraction lower than 35%, allowing protected recovery from severe left ventricle impairment. So we prefer to recommend wearable cardioverter than to implant the defibrillator, because it will be for 3 to to 6 months. And what about transplantation? Cardiac transplantation is reserved for patients where mechanical circulatory support is not possible or desirable, or for patients who doesn't recover after 6 to 12 months, about a year. And what are the recommendations before subsequent pregnancy? It's clear. Recommendations are against the subsequent pregnancy if left ventricle ejection fraction doesn't normalize in women with peripartum cardiomyopathy, because even the left ventricle ejection fraction becomes normal, there is a risk of about 20% of relapse. What about after delivery? What about breastfeeding? For delivery and breastfeeding, what is recommended? Urgent delivery, irrespective of gestation duration, should be considered in women with advanced heart failure and hemodynamic instability despite treatment. And cesarean section is recommended with central tonoaxial anesthesia to prevent abrupt pressure or volume change. Epidural anesthesia might be the method of choice, but should be carefully guided by an expert anesthetic team. And the unstable congestive heart failure, vaginal delivery is preferred, can be the way of delivery, and in heart failure with reduced ejection fraction, breastfeeding is discouraged in more severe cases, and stopping lactation reduces the high metabolic demand and enables early optimal heart failure treatment. So breastfeeding isn't encouraged when we have a patient with a severe heart failure disease. And what is about contraception? Contraception should be discussed at the time of diagnosis or prior to hospital discharge, and I'd like to focus that the importance of contraception should be emphasized by the cardiologists as well by the obstetrician and gynecologist. And I think to avoid the increased risk of thromboembolism, we should avoid the use of estrogen-containing contraceptives. This is my slide to conclude. I think that pregnant women who have heart failure need multidisciplinary management to avoid the sudden death, to diagnose the early diagnosis and heart failure, and to manage correctly this heart failure in a patient in order to recover and to avoid relapse. But I think that we need epidemiological data, we need Middle East and Africa data, so I hope that one day we succeed to conduct our Middle East and Africa registry about cardiovascular disease and during pregnancy. And I hope to I'd like to invite you to our meeting, which will be held next week, the 5th, 6th, and 7th of November, online. You will come. We're very happy to see you online, and we will have also a session about heart failure, hot topics in heart failure, with the Heart Failure Association of the European Society of Cardiology, and Dr. Magdi Abdel Hamid will be with us. Thank you very much.
Thank you, Dr. Leila. For the sake of time, because we're much behind the schedule, so we have to shift to the next speaker, and it's my pleasure to introduce Dr. Hadi Skouri, who is Associate Professor of Clinical Medicine, Director of the Heart Failure Program at the American University of Beirut Medical Center. He's a board member of the Lebanese Society of Cardiology. He's going to present his review on a very important question we face it daily, which is the hyperkalemia management in heart failure. Dr. Skouri.
Okay, good evening. I was unmuted. Good evening. Thank you. I would like first to thank you, the esteemed moderators, and I would like to thank the Heart Failure Working Group of the Egyptian Society of Cardiology, especially my dear friend Magdi Abdul Hamid for all his excellent efforts and work. And so today, my topic is today about management of hyperkalemia and heart failure. As has been mentioned by Professor Magdi, that it's an important and it's an everyday time clinical practice that we see patients with heart failure presenting with lab tests with a high potassium level.
Dr. Hadi, please make the slides full screen.
Okay, I have no disclosure for this presentation, my outline. First, I would like to define hyperkalemia and what are the causes of hyperkalemia, especially in heart failure. What about hyperkalemia and heart failure trials? How to treat hyperkalemia and the new modalities of treating hyperkalemia, and what are the gaps of evidence and the future perspective. We know that potassium is the most abundant cation in the body. Most of it, 98%, is intracellular and only 2% is extracellular. It's the regulation of potassium between the intracellular and extracellular is complex, and usually there is an active uptake and a passive leak of potassium to the extracellular space. The long-term management or homeostasis of potassium mainly occurs in the kidneys. Kidneys excrete around 90-95% of the potassium through the influence of aldosterone, and only 5-10% is excreted by the colon. In patients with chronic kidney disease or advanced kidney disease, the colon will compensate by excreting more of potassium. Most of the potassium is freely filtered by the glomerulus and absorbed in the proximal tubule of the loop of Henle. 10% will reach the distal tubule, and this is mostly through the Darras effect. But the more the potassium intake, the more is the excretion in the distal convoluting tubule. In the short term, and if we want to treat potassium high hyperkalemia acutely, mainly skeletal muscle homeostasis, which is important because total skeletal muscle pool it accounts for around 225 times that of extracellular potassium content. Hyperkalemia. Hyperkalemia is defined as a potassium of 5 milliequivalent per liter, but it can be divided into mild, between 5 and 5.5, moderate hyperkalemia between 5.5 and 6, and severe, which is more than 6 milliequivalent per liter. What are the causes of hyperkalemia? We have etiologies secondary to excess of potassium intake, potassium supplements and diet, and I will show you in the next couple of slides what are the diet that is high in potassium, in addition to enteral nutrition, example some formulas with electrolyte contact, or either potassium redistribution that happens in acidosis, hyperglycemia, insulin resistance, and certain drugs like digoxin, hemolysis, strenuous exercise, and in oncology patients, tumor lysis syndrome, and reduced excretion. And this is what happens in heart failure patients. And usually heart failure patients, in 30 to 40%, they had impaired renal function, type 2 diabetes, and they are on RAS inhibition. So there are several elements in heart failure that can reduce potassium excretion. This is from the consensus statement of hyperkalemia management in patients with taking RAS inhibitors, published in 2018 by the European Society of Cardiology, with the first author, Professor Rosano, who is a faculty of this meeting. And he divided the the drug substance causes of hyperkalemia into that decreased potassium excretion and that increased potassium intake or administration. Those that decrease potassium excretion include potassium-sparing diuretics, spironolactone, for example, non-steroidals, ARNIs, sacubitril/valsartan, RAS inhibitors, ACE or ARB, direct-renin inhibitors, etc. And most of these that I have mentioned, they in heart failure patients, while increase in potassium intake, usually potassium supplements, or salt substitute, which I see in Lebanon here, but I don't know in other places. They buy salt for hypertension. It's low in sodium, but it's high in potassium, and they overuse it or overtreat it, fruits, etc. So these are examples of some food that is high in potassium. I usually know that banana is high in potassium, and in heart failure patients, I try to tell our patients to reduce banana, but also sweet potato is important too. Plain yogurt, carrot juice, orange juice, these are very important, and apricot, dried cooked, and spinach, tomato juice, all these that we should our patients to try to reduce the intake of these in order to reduce sodium and potassium in their diet. And we all know that treatment with ACE inhibitor, ARBs, ARNI, or MRAs, though all these, they increase the risk of hyperkalemia because they increase potassium retention and increase sodium, reduce sodium and uptake, sodium and water uptake. So always there is an interaction between the heart, the diabetes and the kidney status, and the use of MRAs and RAS inhibitors in the development of hyperkalemia in heart failure patients. So in addition to medications, renal dysfunction, diabetes, there are other causes like age, frailty, that can increase potassium in some instances. So what are the limitations to RAS pathway? Always we are limited to uptitrate heart failure medications, MRAs and ARNIs or RAS or any RAS inhibitors because of hypotension, because of increase in creatinine or reduction in GFR, as well as in rise in potassium, which is important, hyperkalemia. And this will lead as an initial reaction to either stop the medication, hold the medication, or avoid initiating a medication, like avoid initiating mineralocorticoid receptor antagonist. And as we can see from different registries and from additional trials, like the recent qualified trial that showed that most importantly, patients that were not taking cardiac heart failure medication, the RAS or the MRAs, was secondary to low blood pressure or development of hyperkalemia, and mainly those that are not taking MRAs, mineralocorticoid receptor antagonist, was due to a history of hyperkalemia in these patients or a chronic kidney disease. And this will affect uptitration because it has been shown that patients who are on more than 50% of target doses of heart failure therapy, they do better concerning mortality and rehospitalization and improving quality of life. So reducing these medications is going to affect more survival in these patients. This is a summary of some of the major heart failure trials, whether in reduced ejection fraction or in preserved ejection fraction, and the use of ACE, ARB, or ARNIs in this population. And we can see the incidence of heart failure varies because it depends on the definition. The incidence of hyperkalemia varies because it depends on the definition of hyperkalemia, whether above 5 used in this study or above 5.5 or above 6. And in most trials, it was defined as hyperkalemia, a potassium above 4.5. I would just want to just highlight the RAISE trial, which was on spironolactone versus placebo in class 3 and 4 heart failure and the low ejection fraction. And if the definition was a potassium more than 5, 51% of the patients in the treatment arm developed hyperkalemia compared to 28% in the control arm. While if it's more than 5.5, 19 versus 5.6, and if potassium defined hyperkalemia above 6, which is severe hyperkalemia, only about 2% or less than 2% of the population. The second trial, which I will elaborate more in the next couple of slides, is the newest trial in the RAS inhibition groups, and it's on angiotensin receptor neprilysin inhibitor PARADIGM-HF, which is secondary valsartan versus placebo in class 2 to 4 with an EF less than 40%. Around 16% of the patients in the treatment arm developed a potassium of 5.5, and the control, which was an ACE inhibitor in April, around 17, while a severely hyperkalemia, it was around 4.3 versus around 5.5. Concerning HF5 trials, Charm preserved and I preserved and TopCat, the average was between 3 and 5 to 6%. They developed hyperkalemia in this population. 6% goes to the TopCat because it was with MRAs. Back to the PARADIGM trial, we just want to remind you that at screening, before run-in period, they excluded patients with hyperkalemia and the GFR less than 30. And during the run-in period, which was around 4 to 6 weeks, they disqualified all patients who developed hyperkalemia. So after randomization and after excluding at screening and in run-in period, just 1 in 6 patients, around 16 to 17% of the patients in the PARADIGM trial, whether in the placebo enalapril arm or secondary valsartan arm, developed serum potassium level above 5.5 during the 27-month period duration. Also, this has been seen in the Pioneer heart failure trial, which was in stabilized heart failure patients after an acute heart failure episodes. And we know that was a positive trial with significant reduction in the secondary valsartan arm, but 10% of this population in 8 weeks or within 8 weeks, they develop hyperkalemia. And in the PARADIGM trial, serum potassium was higher in the enalapril group compared to the secondary valsartan group. And even if we look here, patients who were on enalapril and MRAs have the highest potassium level compared to patients who were on secondary and MRAs. Usually, if there was no MRA, there was a lower potassium level. So the change in potassium level at week 8 between secondary valsartan and enalapril was significant, whether they are taking MRAs or not taking MRAs, favoring secondary valsartan for a less hyperkalemic effect compared to other ACE inhibitors. In this example is enalapril. Also, what is the incidence, predictors, and outcome of this kalemia, whether hypo or hyperkalemia, in different ranges of ejection fraction, whether preserved, mid-range, or reduced ejection fraction? So any hyperkalemia above defined as a potassium level above 5, there is around 20 to 25%, whether in all the ejection fraction, and on overall 24% they developed hyperkalemia, and severe hyperkalemia and up to 10%. But on the other hand, hypokalemia is also prevalent in the same percentage, less than 3.5 in around 20%, and less than 3 in around 3 to 4%. But what are the risk factors for hyperkalemia? Male sex, baseline potassium level, which is on the higher side, lower GFR, anemia, diabetes, chronic kidney disease, COPD, and increased amniotic gas, and the use of mineralocorticoid receptor antagonists. And as we know, if the patient with heart failure, they have at the same time chronic kidney disease, which occurs in 30 to 40% of this population, and they are labeled as cardiorenal patients. So hyperkalemia incidence increases with a lower GFR, and it increases too when we add spironolactone to ACE or top of ACE or any RAS inhibitors. So an MRA over an RAS inhibitor in a GFR less than 60, this incidence of hyperkalemia doubles, and it can reach up to 25 to 30% in this population. And what is important about the development of hyperkalemia is either down titration of the class 1 heart failure medications or discontinuation of these medications of heart failure, whether they develop a mild hyperkalemia, moderate, or severe hyperkalemia. And studies have shown that hyperkalemia increases risk of is associated with increased risk of mortality, and if patients, they have multiple comorbidities, let's say as heart failure and the chronic kidney disease, this mortality increases more, doubles, and if these patients have heart failure, chronic kidney disease, and diabetes, the risk of probability of mortality even increase higher and higher, times 2 or 3 times that of patients only they have heart failure or diabetes. And all-cause mortality has been shown to increase for every 0.1 milliequivalent per liter change in serum potassium. So in heart failure with reduced or preserved ejection fraction, both hypokalemia and hyperkalemia were associated from different studies and registers with worse outcome. Hyperkalemia often leads to RAS inhibition discontinuation, which is important. Potassium normalization has been associated with better outcomes in these patients, and using potassium binders, it may improve or help in uptitration of RAS inhibitors. Similarly, in HFpEF patients, often it leads to RAS discontinuation, and normalizing potassium level is associated with a better outcome. So patients who are hyperkalemic and they are being treated with a potassium binder to reduce potassium level and continuing RAS inhibition, they have a less probability of death compared to patients who stopped RAS inhibition on these patients. So what are the guidelines saying about, or the recommendations of renin-angiotensin-aldosterone system used in patients with hyperkalemia? Usually, if a potassium is above 6, we have to stop the RAS inhibitors. With above 5, either we have to reduce or stop ACE or ARBs and stop MRAs. Above 5.5, above 5, we have either to reduce close monitoring or half the dose of the medication, and usually between 4.5 and 5, we uptitrate the medication, RAS inhibition, and MRAs, but with very close observation. And nothing has been said in the previous 2016, 2017, and the prior guidelines concerning any potassium binders for the treatment of hyperkalemia. So in general, hyperkalemia treatment depends if it's an acute with electrolyte, with EKG changes, with other and with the acuteness of the hyperkalemia, and it depends if it's in the chronic situation we use only as like maintenance phase. So in the emergent situations, we use calcium gluconate, insulin, and beta-adrenoceptor agonists. In patients who are good diuretic resistance, we may go to dialysis in these patients. We may use other diuretics, or we use sodium bicarbonate. but in the maintenance phase and the chronic heart failure, we have to check for low potassium diet and emphasize it. We have to review the medical list and dietary supplements, reduce dose of RAS inhibition, or stop offending other medications, and we have to use potassium binding resins. So the mechanism of reduction in potassium, it can go either by insulin and beta-2 agonist through the potassium-sodium ATPase exchanger, where we have to increase more sodium or potassium to the intracellular space. Bicarbonate goes with the bicarbonate potassium co-transporter, causing more potassium into the intracellular fluids. Loop diuretics will cause more potassium and sodium excretion, and the sodium binders and the potassium binders, whether sodium zirconium cyclosilicate, sodium polyesterase sulfate, and petiromer, they all work on the column and the GI to bind potassium and reduce absorption. I will go over them more in details. So the management of hyperkalemia and heart failure, we should always be worried about the clinical inertia. We should not stop RAS inhibitors immediately. We have to look for causes. We have to escalate the dose of when appropriate. We have to take a good medical history, include current and past medications, to assess what is the risk of hyperkalemia. Always our aim is to optimize the dose of the RAS inhibitors, because it proved that it will improve survival and reduce hospitalizations. And in the recent 2019 Heart Failure Association Expert Consensus Meeting report, they included the use of potassium binders, whether petiromer or ZS9, in selected patients with heart failure plus minus chronic kidney disease if we are not able to up-titrate RAS inhibitors and MRAs in these patients. Also from the consensus document published in 2018, they recommended in certain cases with a chronic or recurrent hyperkalemia on RAS therapy to start potassium binders. Also with a chronic or recurrent hyperkalemia, not on maximum tolerated guideline recommended target dose of RAS, to use potassium binders. And even in severe hyperkalemia with a potassium of more than 6.5, we have to discontinue any RAS or MRAs, treat with potassium lowering agents, and when the potassium is around 5 or less than 5, we can continue the potassium binder and resume RAS inhibitors or in addition to MRAs in these patients. So there are two novel agents for the management of hyperkalemia, the petiromer and the sodium zirconium cyclosylate, which is ZS9. They usually normalize and maintain potassium level. They are efficacious in heart failure and reduce aldosterone levels and blood pressure. Nothing without side effects. Some have drug-drug interaction. ZS9 can cause edema, others can cause constipation, diarrhea, and some GI adverse events, whether mild or severe, and some electrolyte abnormalities like hypokalemia and hypomagnesemia. We all know about Kegzalate, which was approved in 1958 in the USA, in 1980 in France, to treat hyperkalemia. It can bind sodium, potassium, calcium, works mostly in the column. We have to take it 4 times daily, and the normalization of serum potassium is variable and not known. Normokalemia maintenance is also variable and not known, and it has a lot of drug-drug interaction with antacids, laxative digitalis, lithium, and thyroxine, and these are some medications that are used in heart failure patients. And in 2009, there was an FDA safety alert because Kegzalate with sorbitol can cause colic necrosis and other serious GI adverse events, and they recommend it to be used with caution and preferably not to be used in high-risk patients. The other 2 medications that I will concentrate on are the petiromer and the sodium zirconium cyclosystate. Patrimour was approved in USA and in 2017 in Europe by the name Viltaza, and sodium zirconium cyclophosphates approved in 2018 also in Europe and by the FDA. And both these drugs, they work on the GI tract. Patri-Romer works in the colon, and it can bind to other than potassium, to sodium, calcium, and magnesium, while sodium zirconium only binds selectively to potassium and works on the entire GI tract. They can be taken on a daily basis, PO medications, and some on a weekly basis. And the efficacy is in the zirconium in 2.2 hours. They normalize sodium potassium and they maintain it for 52 weeks. While in the other group, Patri-Romer, it's for the normalization of serum potassium occur in 48 to 72 hours. Zirconium can cause some lower extremity edema, and the other Patri-Romer can cause 6.3% worsening of chronic kidney disease and some electrolytes imbalance like hypomagnesemia in up to 24% and hypokalemia in around 6%. And it must be taken 3 hours apart from the oral drug, while in the zirconium, till now, there is no clinically meaningful drug-drug interaction. So there are a lot of completed clinical trials with these novel potassium binders, including the OPAL-HK on Patri-Romer, and the PAL-HF on Patri-Romer, and the ZS005 on the zirconium. This is the results of the ZS005. And these patients, they treated them for 1 to 3 days with a loading dose, induction dose, and then when the potassium normalized, a long-term maintenance dose. It included 751 patients with a potassium level of more than 5.1 and a GVR less than 60, and around 65% of these patients, they were on RAS inhibitors. There were some events, adverse events like constipation, peripheral edema, and worsening hypertension in up of 5 to 8%. But what is important that 74% of the patients maintained on RAS dose, while 13 increased their dose in the arm taking the ZS009. So most of these patients, either they up-titrate or they stay on the same dose without lowering or discontinuation. The OPAL-HK was a phase 3 trial of single-blind placebo control of 243 patients CKD and heart failure with a potassium level between 5.1 and 6.5, receiving at least one RAS inhibitors, and it showed that it reduced significantly potassium level by 4 weeks, and 76% of the subject had serum potassium in the target range within 4 weeks. And what is also important, 56% of the control arm, they discontinued RAS compared only to 6% on the study arm. And the third is PAL-HF, which is a phase 2 randomized clinical trial of the placebo-controlled trial using patients with heart failure, CKD, EGYHF less than 60, documented hyperkalemia, and they either give them potassium placebo or Patri-Romer. I started them with spironolactone 25, and after 15 days, it increased to 50 milligram. And we can see here on the left lower, the patient on the treatment arm, they continued with 50 milligram without increase in potassium level. Not only that, even in lower GFR, or placebo has more hyperkalemia than patients on the drug arm, which was significantly higher, and more patients, we were able to increase their MRAs to 50 milligram compared to placebo. And 91% of patients on the drug had spironolactone dose increased to 50 milligram versus 74% in the control, and it was statistically significant. There are also ongoing trials. These trials, they either studying the effect of RAS, the dose of RAS inhibition, and the maintenance and the addition of spironolactone, but there are some trials which they are studying some endpoints that are important in cardiovascular disease, like cardiovascular death or cardiovascular hospital, because these endpoints are important to include the patients, to include these medications in the guidelines. There is the prioritized heart failure study, which uses sodium zirconium cyclophosphate, and it tested how to intensify RAS inhibition therapy over a 3-month period. And the other one, which is important too, that we are waiting it, the Diamond study, which studied patients with low ejection fraction, serum potassium level above 5, and either with a GFR above 30 on RAS inhibition, and they blinded the patient either to Petrimor or placebo, these drugs, and wanted to see the effect of cardiovascular mortality and hospitalization of this population over 3 to 8 weeks post randomization. And last but not least, this is from a review article published in JACC recently, 2020, by Ferreri, about a proposal for potassium binder use. So if a patient less than 5.5 potassium, we have to maintain guideline recommended medication therapy. We don't stop potassium binders. If the patient is taking one, we should consider potassium binders between 5 and 0.5 if the patient is not on optimal dose and we need to increase RAS dosing. While if the patient has a potassium between 5.5 and 5.9, we should adjust MRA dose. We should not reduce ACE inhibitors. We should reassess potassium level after 1 week. If it's still high, it's preferable to start with a binder and reassess after another 1 week after the binder. If the potassium level is less than 5.5, we can increase MRA or initiate MRA, but if it's above 5.5, we have to keep away from up-titrating or increasing MRAs. Similarly, for a potassium more than 6, we have to reduce ACE, we have to stop MRAs, we have to start the binders, and when the potassium level is less than 5.5, preferably 5, then we can initiate ACE ARBs, increase them, up-titrate them. If the potassium is still okay, we can up-titrate MRAs. So my take-home messages: newer potassium lowering agents are effective and well tolerated, as we have discussed, with some side effects that can be tolerated to treat hyperkalemia in patients with heart failure as well as heart failure with cardiorenal syndrome. These newer potassium lowering agents could enable optimal use of RAS inhibition, and this is the aim in heart failure management, to reduce mortality. But what is needed in the future, and we are waiting the Diamond and other trials, because we need hard outcome studies so that it can be used more abundantly and more thoroughly and in a way. I will end here. Thank you for listening, and I am open for any questions.
Thank you very much, Professor Hadi. Excellent presentation, highly informative. You summarized everything related to hyperkalemia, from causes up to management. And I think the role of potassium binders will allow us to use the guideline-directed medical therapy in optimal doses, ACE, ARBs, ARNI, MRA, without the risk of hyperkalemia. So I think the new guidelines maybe add the recommendations for the potassium, because you know that in the guidelines did not mention in the guidelines the new potassium binders, when to use it, the recommendations to use. Do you agree for this?
So in 2016, ASC guidelines, neither ACC 2017, they mentioned the potassium binders, and they mentioned if the patient developed hyperkalemia to reduce the dose or stop the dose of ACE or ARBs. But in the update of the HFA consensus statement on the guidelines in 2019, there was a section on potassium binders, and they recommended it in heart failure plus minus chronic kidney disease in certain situations One, if they have cardiorenal syndrome, persistent hyperkalemia, and the other, if they are not on optimal medical therapy still, not on optimal rest, not on optimal MRAs, and they have hyperkalemia to start these binders. But I think this was just a message prior to the 2020 guidelines, which should be in the guidelines. Here in Lebanon, we don't have these binders yet, but hopefully they will be available in the near future. I don't know in other Arab countries attending now if they have these binders.
We don't have it in Jordan either.
Okay, thank you very much.
One important thing really is diet, because I have been subjected to many patients actually, and just taking a good history from these patients for this persistent hyperkalemia, you see that they are eating a lot of bananas, sweet potatoes, dates, any dried fruits, apricots, because it's here known to be healthy, the dried fruits in our region, so they try to eat it. Even in the Gulf region, dates are high with potassium, and this can help. One of my patients, he was eating a lot of dates, and I questioned him about dates in specific, and he said, yes, I eat a lot every day, I stopped dates, and I was able to increase RAS inhibition on these patients. So before thinking of binders, we have in our region here, because of the lack of binders, and for sure they are going to be very expensive, we should start taking a very good history and discover other extra cardiac or extra causes of hyperkalemia in our patient, especially salt substitute with potassium chloride. This is important too, because it's been marketed as it doesn't cause hypertension, and a lot of patients, they just buy these to eat salt instead of the regular salt, and they develop hyperkalemia too.
Thank you, Professor Hadi, and we will move to the next speaker.
Thank you.
Thank you. It's my honor and pleasure to introduce Professor Khaldoun Hamoud. He is a real expert in heart failure and cardiac transplantation, which is now it's a growing specialty that not only in heart failure and transplantation and improving these kinds of patients. Dr. Khaldoun is a consultant in Kuwait. He's director of the Advanced Heart Failure Transplantation at Kuwait National Heart Transplantation Program, and he's also a member of the National Amyloidosis Program in Kuwait. So please start, Professor.
Thank you very much for the kind introductory. Well, I'm going to go all the way until tomorrow with the lecture. I don't know. I'm going to share my slides with you. Yes, share. I'd like to thank the organizing committee for this amazing opportunity. The whole esteemed members, my good friend, Sir Magdi Hamid, and for giving me this opportunity. Okay. Can you see anything? No?
Look yet.
I told you you were going to go until tomorrow. I don't know what happened. Okay, here we go. Okay. So, without further ado, we will run through the whole dilemma of, people know, we read about it a lot in textbooks as an option of therapy, transplant, destination LVAD, and people would like to know when to choose what and what is the best option for which patient. So you got my slides?
Yes.
Okay, lovely. Okay.
Yeah, thank you.
Let's go. So my agenda is going to talk about what is advanced heart failure. When do we consider a patient candidate for these therapies? Who is the best candidate? Something about left ventricular assist devices, what are the strategies, something about heart transplantation, and what therapy to choose, and then a take-home message. Now, a quick review when we talk about the weak heart, thinking about the common analogy of the weak horse. Well, if you have a weak horse pulling a wagon, you might whip the horse just to let it go. Like when we give inotropes, you could unload the wagon just to make it easier by anti-RAS or diuretics. Slow the horse down. You can get a new horse, or you can add a tractor instead of the horse to assist the horse. Or you might think about healing that horse if it could go on again, like if there is arrhythmias or PCIs or cabbage or valves to be fixed, maybe you can go back on track. We go through all the evidence-based therapy, and optimum medical medication. We got all these nice fancy new drugs coming that we knew and the new that we haven't been introduced to. And we put on devices, whether it's a CRT or an ICD or survival or symptoms. And then we try to reach, this is my summary slide. I love this slide. I kind of everything here. My aim is to get the patient euvolemic NYHA1 with a good blood pressure, even barely at above 90, I would be happy if he's not symptomatic, a heart rate less than 70. This is my optimum patient. And by that, I try to reach that with maximum RAS, maximum ARNI, if not RAS, beta blockade, maximum MRAs, SGLT2 if diabetics, even for non-diabetics, Ivabradine if indicated, CRT if indicated, minimal or no diuretics. If I do this, I think I reach the win. This is not always the case. You know, some patients come in cardiogenic shock. You give them inotropes, mechanically ventilated. You want to see maybe there is a reversible thing. They could recover. They could be a reversible, like they need reperfusion by PCI or cabbage or lysis, and then they recover. If they fail to recover, maybe I need to put the temporary MCS, put an aortic balloon, an ECMO, Impella. They might recover, they might not. If they don't recover with that, I wait, nothing happens. I end up with the need of a durable VAD, and then that VAD would go, should I keep it there forever, or should I go with a transplant? It depends on time. We're going to go through that. So when do we call it advanced treatment? So this is the this is the more detailed one. I'll just put an executive summary. When you have a patient that you are following who is NYHA3B24, he has a low LV ejection fraction, or we are talking about this was put with an isolated right ventricular failure as well. Again, you can, because this is when you use an RVAD or an LVAD. Patients congested on a high dose of diuretics, and what we mean by higher dose, it's not the 500, it's just as long as they require more than 160 per day, then that's considered these are patients on a dose, on a considerable dose of diuretics. You don't want that. Patients who show signs of hypoperfusion, sometimes they need inotropes at some point, and those with weak functional capacities, with a 6-minute walk less than 300, or a cardiopulmonary exercise test, a CPET with a peak CO2 max of less than 14 or less than 20. We do in our patients, part of our evaluation for those who need on advanced therapy is we subject them to a cardiopulmonary exercise test, which is a more objective definition of the maximum exercise capacity through measuring the peak oxygen and PO2, and it gives us a value. In some literature it's 12, some guidelines it's 14. Just to see, so if somebody gives you a good VO2 max of 20, or sometimes you say you are still beyond advanced treatment of transplant. We get those patients before we do anything. We classify them. We classify them based on their NYHA. We know we classify them based on the stages, on their severity, based on what type of heart failure, based on the etiology of heart failure. All of these are different classifications that we really need to put the patient in the right box. So when we stage them, we look at, of course, we have to remember the ABCD. So am I dealing with an A A patient who patient is just as dressed, normal EF, no symptoms, he only diabetes, hypertension, obesity is at risk, we want them just to improve their quality of life. Is it a patient who's asymptomatic but incidentally found to have a low EF? Then we need to initiate anti-failure therapy, although they are asymptomatic. And then there is the C group, which are the common, most our bread and butter, which are the symptomatic low EF patients. And of course, they need to be on optimum medical therapy. And then we have the stage D, which are the stage intractable refractory cases, very low EF and very enriched refractory to therapy, where they're unable to maximize or cannot tolerate medical therapy. You have to keep in mind that these are fluid, and patient could present to you with a stage C, but with time he becomes a stage B when he's asymptomatic on good therapy. And this is when we escalate therapy based on that. We start with lifestyle modification of the ACE and the beta blocker, and then up with all the devices and everything, and then we reach the point, stage D, where we start with inotropes and all dangers. We know this common graph where we say the patient was doing very well. He was not an heart failure. He's a stage A, normal EF asymptomatic. Then he starts to be maybe found in the medical service to be low EF, and then he starts to develop symptoms, recurrent admissions until he reaches a point where failure occurs, and then we need to interfere. We classify them once we see those very, very sick patients. We want to see whether they are warm and dry, wet, dry, wet, based on their congestion and their hypoperfusion. This is all common knowledge, of course. So who deserve advanced therapy? I just have to go through this homework. It's the Goldilocks position. Everybody knows that childhood story from our childhood about the not too good, not too bad, and it should be just right. You don't want to aim to that very, very sick, debilitated end state, the patient who's very sick, or the patient who's doing very well and has room for therapy. So we need a proper classification to know which is the patient that is not too good and not too bad, but just right. Those with a low EF, those with symptomatic intermax 4 or less, and that's right, because I'm going to go through this classification. And no response to medical therapy, gave them 6 months on maximum medical therapy, with 6 months of therapy on maximum doses and nothing. Either you fail to maximize the dose, or the patient cannot, is still symptomatic on everything, or they are intolerant as dead, or recurrent hospital admission due to volume overload requiring IV diuretics, sometimes inotrope. So what is the intermax? The intermax is the classification we use when we talk about advanced heart failure. We end with the stage 4, we stop there, then we need to subclassify. Anytime? It's implanted into the apex of the left ventricle. It's a small, lightweight device. It's the size of a golf ball. It can pump up to 5 to 10 liters per minute. They put a ring first, they sew the ring, and then they make a cord, and they fix the device into it, and then put the conduit onto the ascending aorta, and through anastomosis, and then the blood is sucked from the left ventricle to augment the cardiac output, and it has a centrifugal, blood goes through the machine, through magnetically levitated centrifugal pump, which pushes the blood all the way into the circulation. And the device comes, of course, with batteries, controllers, and a lot of things. And there is a lot of monitoring and care that has to be provided afterwards. So when we look at the statistics, comparing two transplants, the this is the optimum medical therapy, which has the best you can do. Patients would have, the survival is around, on the rematch trial, and 50% will die in 6 months, 25% will survive up to a year on optimum medical therapy. But with the early devices, the axial, all the pulsatile devices improved survival a little bit, but not to the level of the new devices where they're almost reaching the level of heart transplantation. And of course, studies show that this is the REVOLVE study, which shows that half of them would survive 7 years, which is an excellent, because you are comparing at a patient that was, his death was very imminent in the very close future, within months. There are so many indications for LVAD. Some patients, we call them a destination therapy, which is they are contraindicated for a transplant. This device is the last destination for them. They are either old for get a transplant, or for instance, HIV patients that you cannot give them immune suppression. There are the bridge to candidacy, which they are not fit for transplant now, but maybe they could become candidate, those with severe pulmonary vascular resistance, high pulmonary hypertension, morbidly obese patients, or recently remission from malignancy. You need them to be for a while in remission before you start them on anti-suppression treatment, because it would save their malignancies. There are patients, we call them bridge transplant. They need a transplant, but there's no donor available. We put a device, just wait until a donor is there, and we call them back just to get a transplant. And then there are bridge to recovery. It's a very, very low number of patients, around 5%. We shouldn't give our patients a lot of hope about that, but it could happen. I have explanted 4 or 5 patients from LVAD. There are lots of contraindications for LVADs, those with the irreversible multi-organ failure, not those due to drop of like cardiorenal due to the shock, maybe they could recover, but those with irreversible end organ failures, major coagulable problems, certain, strong neurological deficit, large strokes, brain bleed, inactive sepsis, those with severe RV dysfunction. And I will explain why this is a nightmare for us. We always, before we think of an LVAD, we think of the RV. And there are relative indications, such as, we prefer not to put it with those with questionable psychiatric issues, or no with family support, because it's a problem. Now, the RV post-LVAD problem, this is a thing that everyone should keep in mind. This is my own analogy. I stated this. I say that if I had a good right ventricle and I had a poor LV, the right ventricle would carry the blood along with the poor LV. It's just going to couple with it. It's fine. But when we have a poor RV and a poor LV, it will just, augment each other, and they will walk very slowly together, and things will go smooth. But when we have a very poor RV and it can't catch up with a good LV, in normal physiology, if we have a poor RV, we see there is a gradual kind of adaptation between them, and they try to think things together. But when we put an LVAD, we have a sudden correction of the LV output, which is so rapid emptying of the LVAD that it makes it very, very difficult for the RV to catch up with it. So that's why the RV falls. If we had a poor RV and we put an LVAD that starts running very quickly, and the RV cannot catch up with it if it was poor at the beginning, we really need a good RV to run with an LVAD. Otherwise, you're going to very, very serious problems. These are some of our patients who are happily got their LVADs and doing well. Let's talk about one case. For one of these patients is a 27-year-old, where things were going so well until 2018. He was just married and learned that his wife was pregnant. He has a job in an electric plant. He's healthy, active, loves to travel. He was admitted first as a diagnosis of pneumonia. When they admitted him, I received a call, and they told me this patient actually didn't have pneumonia. He had a cardiogenic shock. He had been with a mobile LV thrombus, request to be transferred under our care at the heart failure team. When I saw him, he arrived cold, wet, he was hypotensive, heart rate was 70, obtunded, sick, pale, clammy, creatinine was high, sodium was low, lactate was high, and transaminases were high as well. I was surprised to see him on the medication Furosemide was 20 only because they were afraid of hypotension. Was on ivabradine, beta blocker, ASMRA, digoxin. This scared the hell out of me because I realized there are people who think that if you give anti-failure therapy, people do well. But he was in cardiogenic shock. What I did, I stopped the ACE, ARB, beta blocker, ivabradine, digoxin, MRA. I started him on a dose of beta blocker and nootropics with milrinone and dopamine with heparin for the LV thrombus. The next morning I came, he felt immediately very, very well. He was sitting upright, talking to me nicely. His CVP went down to 17 from 25. His blood pressure improved. His heart rate came down. Sodium was better. Lactate was better. I did a right heart cath immediately. Next day, his weight was 26. His PA stats was 52. Mean pulmonary 35, cardiac index 1.7. I increased the milrinone, tapered off dopamine, and continued diuretics. When you looked at the X-ray, I thought, oh my goodness, what is this, massive effusion or whatever? But if you look at the trachea, you see it's deviated towards the lesion. If it was an effusion, it should be away. That's common sense. But, and I'll tell you why. This is his EF as his echo, and it was very poor LV function, 15%, but the dimension of the LV was not dilated. I came to the past medical history. When he was 10 years old, he was diagnosed with a right lung teratoma, seen in UK, Germany. They did a right lobectomy, so that's what it was. He had a lobectomy and had chemo and with doxorubicin, radiotherapy on the chest. So this caused a lot of fibrosis. So over 10 years later, the patient, or 15 years later, the patient actually developed, I think this is chemo-induced cardiomyopathy. And again, after a while in 2013, he developed TB of the lung, which is also treated. So it was and he's failed to thrive. You look at, he's a short man compared to his brother. His brother and father are really old people. He did the workup initially, blood group was O positive, immunology was negative, virology negative, scan was negative, cardiac MRI showed no late gadolinium enhancement. So we discharged one low dose of anti-failure medication to uptitrate this outpatient. He struggled to maximize the medical therapy due to soft blood pressure, but he had recurrent admission of volume overload and requirement of IV diuretics. ICD was implanted afterwards, and he was asked to board TSA. We facilitated that to him. He went to the USA in June 18, and they worked him up. He had for transplant, but due to limited lung function and a single lung, he was sent back to Kuwait on end of June to be managed medically. Nothing for him, no transplant. They said one lung get infected, the guy will die. So we will not subject him to transplant, and there is no room in the chest for a heart lung transplant. So good luck for him. He came in end of June. So by 13th of August, he was admitted with recurrent VTVF and multiple ICD shots. He was feeling very weak and hypotensive and sick. EF was 20, global hypokinesia. Now I noticed that the LVEDD started to dilate. His RV was moderately depressed, but we had no way to go around it. We had to implant an LVAD on him. There was no complications, smooth hospital stay. He leaves. He left the hospital in short period, regular follow-up on outpatient, and he is now a happy father of a 2-year-old boy and doing pretty well. We tried again to offer him transplant after the LVAD, but again, he still remains a destination therapy. We follow him regularly in our in our telemedicine, and he's NYHA1 good, and all his labs are fine. So this is a case of a patient who he's young, but he required a destination therapy because there is no way to go any way than that. Now, on the other hand, we talk about transplant. Transplant is not, as you know, not a new thing. It's done in 1967 in South Africa. Dr. Christian Bernard and performed the first transplant. He got this pain out of it. This patient got the transplant. Unfortunately, he died 18 days after due to pneumonia, but the heart was strong until the end. The transplant medicine has improved and survival improved with improvement of medication and anti-rejection therapy, and we see through the eras that in the 80s, that's the light blue, shows the survival, and by the 90s we had better survivals, by the 2000s we had better survivals, and now we also have better survival. So if we imagine a trajectory, maybe we will have a projection of a better survival up to 20 years in the future. We don't know where we're going. There are lots of complications for transplant. It is not forever. Patients should know that there is it has a shelf life of around 15 years. People could stay for longer or less. Post-operative complications, common bleeding, arrhythmias, heart block needing a pacemaker, infection. They could have antibody-mediated rejection and acute cellular rejection and cardiac allographic vasculopathy, which is a kind of intimal narrowing in their coronaries. The understanding of this phenomena is not really clear. There is multiple theories on that, and there is no absolute way of preventing this other one. Changing some anti-rejection therapy, putting them on aspirin and statin could help. Regarding the rejection, like one patient, I would really send my greatest gratitude to Professor Hamid for helping us with one of our patients who was in Egypt, and he stayed there and he developed a cardiac graft rejection of his heart, and with our amazing collaboration with the team over there, we managed to start a protocol of anti-rejection therapy, and alhamdulillah, the patient got out of it and he normalized his LV function again. And this is, I'm so happy and so glad for this amazing, and I'd like to thank the team in Egypt for helping us with our patient. The other problem is opportunistic infection, like anyone who's on anti-rejection, and again, rise in the level, increase the level of cancer developing malignancies. We see that countries since the 80s, the number of transplants has increased, and then again, mostly North America and Europe, other countries start to pick up. But we noticed that it reached a plateau. The reason is that you want to do transplant to everybody, but unfortunately the graft issue and the donor issue is always limited. So always limited by the number of donors. This is when the bad comes in place and kind of push the thing. So I will give you a case about this hefty, young, happy chap who was doing very well, bodybuilding, and he was previously healthy. He developed, he's 27-year-old, developed acute fulminant heart failure, giant cell myocarditis. So I kind of removed the suspense out of the story. It is GCM, so there's no proper treatment for that. His cardiac index 1.2, came with recurrent attacks, was on inotropes didn't work, he needed an ECMO at a point that his biventricular failure and almost a standstill heart. And we had nowhere to go, and then we had a proper donor at the right time, so we transplanted the patient. So this is the patient after transplant, and he wrote a board when he was in ICU that he's proud to be special, and that he will أظل مبتسم طوال اليوم ومارس العلاج الطبيعي والشكر عرفان للأطباء. That's him after recovery, and that's him now. He's still growing up, and he's a happy person. We invited him on his birthday. He was surprised. He came to the clinic. He thought it was a follow-up, and we surprised him with a birthday party for him. So there are contraindications. Transplant is not for everybody. You cannot put it for somebody who is morbidly obese, BMI more than 40, somebody with a high pulmonary pressure, because pulmonary hypertension with a high pulmonary pressure, the new heart is not adapted to sustain such heart, where the old heart maybe had a chance to adapt for this pressure. If you put a heart in a pulmonary hypertensive patient, it will collapse on the bed. A patient with major mental or physical disabilities should be avoided. Those with abuse, smoking, or ethanol consumers, or drug addicts, frail elderly patients, recent cancer remission less than 5 years, or active cancer, those with non-cardiac survival less than 1 year. If he's dying of another disease, you don't offer them transplant, or they have end-stage and organ failure like lung, liver, kidney, unless you are going to a heart lung or a heart liver. So, how do we make the choice? Transplant versus LVAD, well, it should be through a multidisciplinary meeting, through the HOP team, just to make it, kind of it's an oversimplification, I know, but at least get an educated opinion about it. Those with transplant, you think about when you have a patient with biventricular failure, a patient with a normal PA pressure, if he has an LVAD and starts to develop complications, then you really have to switch to a transplant, multiple valve thrombosis, or he developed sepsis, bad sepsis, giant cell myocarditis. You cannot put VAD on them, so most likely you're going to end up with a transplant. Destination LVAD are those patients who have isolated left ventricular failure with a normal right ventricle. You have to make sure of that. And we don't only depend on the echo. We have to do a right heart cath and get predictors of RV failure through equations like pulmonary artery pressure index and other equations. Those with a high pulmonary artery pressure, which are not improving with therapy, so we need high PA pressure. If you put an LVAD, which sucks the blood out of the left atrium, and they invariably bring down the PA pressure and make them maybe a candidate in the future, or if they don't recover, then they will need the LVAD forever. Morbidly obese patients, TBA, post-LVAD, so if you have an LVAD and you think that you are going to go as a tissue transplant, but unfortunately the patient developed a big stroke, so now you transfer your strategy from a bridge to a destination. A patient who was elderly, you would just put an LVAD to give them a quality of life. HIV patients and cancer with recent remission, you can put a destination, and maybe or maybe not, they will go for a transplant. So my take-home message is this. Identify the stage deep heart failure patients. You really need to put them. For me, all of those patients, once they reach there, they have a red tag on their file, which I call them red track patients, and we keep an eye on them, and we try to prepare them for what's going to happen. First step is maximizing medical therapy. Do not call a patient end stage without maximizing therapy. Remember that those stages are fluid, and a patient could go from one stage to the other and back again. Consider advanced therapy, not too early and not too late. You have to know that it's just like when somebody jumps from a parachute. You don't open your parachute inside the airplane. You don't open your parachute 2 meters above the ground. You really have a room and a time to open the parachute to be survive. So if you use the modality very late, then you're going to have a very bad outcome, and don't blame the treatment, blame the choice of the doctor. As for LVADs, there is a good 50% survival in 7 years. It's not for those with biventricular failure. The INR, you have to maintain always the INR, watch for infection, bleeding, thrombosis. And as for the heart transplant patients should know that it's not forever, it has a shelf life, and it needs close surveillance for rejection, and checking their anti-rejection therapy drug levels, and annual follow-ups and annual surveillance for coronary arteries and for cancers as well. And it is not appropriate for those with a very high pulmonary artery pressure and those with high BMI. And by this, I conclude. Thank you very much.
Thank you very much. Can I thank everyone here, because I was called for a case here, primary PCI. So I'd like to thank Dr. Abdul Hamid and Ahmed Majdi, Amr Zaki for this opportunity. It's really hardcore kind of heart failure management today. We went from the prepartum cardiomyopathy, which I want to say to Dr. Leila, we have a registry, a small one, 66 patients with prepartum from our Gulf Care. And really what we learn from that is high index suspicious, because the presentation is similar to anybody with pregnancy physiology. And we found the commonest presentation in these patients, these pregnant, they had mild to moderate symptoms, and their age about 32. One of them died. Out of 6, 1 died, and 15 had readmission. So really it's nice to go for a registry, I think, for prepartum. Dr. Hadi, of course, presentation great on management of academia. I think we have the binders in the country here, UAE, but again, we are learning. We're not started to use it. I think your topic, Dr. Khaldoon, great, transplantation, but as you know, it's difficult to find right one, but our center started in Cleveland. Now, it's my pleasure to introduce Dr. Hadi, my friend and colleague. Dr. Hadi, I have same case here now. Patient coming with a shortness of breath, basically, and he's 58. We just did a quick echo on him because ECT shows ST elevation inferior, but he got very bad anterior LAD and LCX. So echo is around 15 to 20%. So it's my pleasure to introduce my friend Hadi. Abu Hantash is a great intervention cardiologist, trained in US, internal medicine, cardiology, intervention cardiology. He's a great speaker. Looking forward to your topics, but I'll be doing the case.
Good luck, my dear friend Abdullah. I'm sure you will be able to save this patient from this acute illness he had. Let me start by thanking my dear friend Magdi Abdul Hamid for the kind invitation, and thank all the group of the Egyptian group on heart failure. And I'm so happy to see all my friends around tonight. Can you hear me?
Yes, please proceed.
Okay, because I thought something here as if I'm muted or something. So anyways, this is a picture from the most beautiful place on earth. It's in Jerusalem. I was supposed to go actually before Dr. Khaldoon to set the stage for him to talk about device therapy and heart transplantation by focusing on the patient with advanced heart failure and what management options there are. Some of my slides, he showed them, but let me just take them from a different angle. We all know that heart failure with reduced ejection fraction is a long journey for our patients, relatively long in spite of the high mortality in those patients. They decompensate and they get worsening of the cardiac function, and they keep going worse and worse. The thing is about it that this disease progression is continuum. It's not, there's nothing like a definition of stable heart failure patients. And what we are going to focus on in my lecture are patients here, patients who decline their function. They are actually end stage cardiac failure patients with reduced ejection fraction and increased mortality. Advanced heart failure is not synonymous with stage D heart failure. They're closely related, but it's not the same terminology. Why is that? The American College defined advanced heart failure patients as repeated 2 or more hospitalizations or emergency room visits for heart failure last year, progressive deterioration in renal function, weight loss like cardiac cachexia without obvious good medical reason, intolerance to ACE inhibition due to hypertension or worsening kidney function, intolerance to beta blockers because the patient has worsening heart failure or because of hypertension, frequent systolic blood pressure recordings below 90, persistent dyspnea with minimal effort with dressing or even bathing, requiring rest, inability to walk 1 block on the level ground due to dyspnea and fatigue, recent need to escalate diuretics with furosemide reaching above 160 milligram daily dose or supplementation with metolazone therapy, progressive decline in serum sodium usually below 133, and frequent ICD shocks. So advanced heart failure, yes, stage D, but it's not the same description. The Heart Association in Europe also, the Heart Failure Association, agrees with that. In the 2018 update definition, they added this, which I personally like. People with severe cardiac dysfunction defined by reduced ejection fraction of equal or below 30, isolated heart failure, it's considered advanced heart failure. Non-operable severe valve abnormalities like functional MR, etc. Congenital abnormalities, and look at this here, which is quite interesting, resistantly high or increasing BNP or pro-BNP values, and data showing severe diastolic dysfunction or LV structural abnormalities, according to the European Society of Cardiology definition. So those are important things to look into when we talk about advanced heart failure patients. So when we face patients with advanced heart failure, how do we prognosticate? How do we know what to tell our patients? Well, risk stratification is crucial for any heart failure patient, but unfortunately, little data is specific for patients with advanced chronic heart failure available, because the others are done on ambulatory patients, which most of the advanced heart failure patients are not. What are the clinical features predicting worse overall prognosis in general for heart failure patients and specifically for advanced heart failure? The older the patient, the longer the QRS duration, tachycardia, especially sinus tachycardia, longer history of heart failure since diagnosis with symptomatology, with higher NIHA functional class, and recurrent hospitalization for heart failure and signs of systemic or pulmonary congestion and or reduced cardiac output as shown by lower systolic blood pressure. So these are the clinical features which predict bad outcome. Biochemical markers also can help when they have end-stage organ dysfunction and injury, whether it's in the myocardium, like having high sensitivity to troponin all the time, pro-BNP, which is always above 1,000 all the time, kidney and liver dysfunction, markers of iron deficiency, and we had an earlier elegant talk about that, electrolyte abnormalities including hyponatremia, hypo or hyperkalemia, and hypochloremia, which is also considered part of that. So what are the treatment options? I mean, Khaldun went through the device options and the heart transplantation. Before we reach that stage, we have to understand that advanced heart failure patients, unfortunately, additional treatment of those patients is not as effective in relieving symptoms and improvement of the clinical course of those patients. Resistance to loop diuretics is one of the major hallmarks of advanced heart failure, and strategies to overcome it are of utmost value for sure. How do we overcome the resistance to loop diuretics? Intravenous ultrafiltration, especially with the new simpler devices, will make it an attractive treatment. Alternative to IV furosemide administration, subcutaneous furosemide and IV or oral torsemide, or a combination of acetazolamide and thiazide or metolazone may show some favorable results. Renal replacement therapy can be needed, as well as peritoneal dialysis, of course. Isotopic drugs are frequently needed for patients with advanced heart failure, as well as for palliative treatment for those unlucky patients. Intermittent levosipram administration has been associated with favorable effects on natriuretic required and the quality of life, and possibly hospitalization for heart failure in those patients. So they're not actually completely out of the option until they reach device therapy or heart transplantation. Diuretic resistant heart failure patients with reduced ejection fraction, how do we define it? It's failure to decongest despite escalating doses of diuretics, often with worsening renal function. But we face that a lot in our end-stage heart failure patients. You keep pushing furosemide, they don't diurese very well. All what you're seeing the next morning is worsening kidney function and more hyponatremia. The mechanism is usually related to decreased absorption, decreased filtration, and increased sodium reabsorption in those patients. This figure applies to acute heart failure patients in the CCU, but actually it applies to patients with advanced heart failure in terms of what therapy and medications we can offer to them. The hallmark of what you can choose for those patients, are they congested or not? Are they warm, dry, without congestion, or warm wet or cold wet? And remember that hypoperfusion is not the same as talking about hypotension. The patient can have a blood pressure of 100 and can be hypoperfused. So you need to identify those patients where more medicine can be pushed in terms of their tolerance to the blood pressure, and if they are congested, to push more diuresis and find alternatives. So what are the options for our patients with advanced heart failure? The previous lecture showed us that heart transplantation has been available and effective for over 50 years. Yet few benefit of this for the whole public, for the patients who are doomed with the heart failure, with advanced symptomatology, because of the organ shortage, and the system set up for each country is not that easy at all. LVADs are available as a bridge or as destination therapy, but again, remember, transplantation, you need organ donation, which is not easy. LVADs, you need the right setup, you need the money to, and in some countries, including Jordan where I practice, it's not an easy attainment actually to have patients afford it. CABG may be an alternative for patients with ischemic cardiomyopathy for sure, if you show an underlying irreversibility or hibernating myocardium. You can offer ablation for patients with AF, which might improve their advanced heart failure symptomatology. Catheter-based interventions also can be used recently to addressing mitral from functional mitral regurg, and there are some centers, I don't know if anybody of my colleagues in the Arab world actually have ways to monitor invasively the BA pressure for patients while not in the CCU or even in the hospital. I know that some hospitals in the United States have that capability. Now, let me just focus on a couple of things in terms of the options. You know, mitral clip, functional mitral regurg, advanced heart failure patient, when can I offer it? Well, just remember that the key inclusion criteria for the COAPT study, which showed excellent benefit when you do mitral clip in those patients on top of guideline medical therapy maximized. It was done for ischemic or non-ischemic cardiomyopathy patients with an LVF of 20 to 50%, which can fit the advanced heart failure patients. However, they excluded stage D heart failure, and they exclude hemodynamic unstable patients or patients in cardiogenic shock. Something to keep in mind. I mean, you know, the mitral clip is a wonderful thing, but remember that the data was not actually studied in the patients which we call advanced heart failure in a way. The paradigm heart failure, which used Army and showed us beautiful outcome results with Entresto in patients with heart failure with reduced ejection fraction. The ejection fraction, you know, the mean was almost 30%, but look at this here. The New York Heart Association class 2 actually in those patients were 71%. So you're talking about high percentage of patients who are not actually in stage D heart failure or even in advanced heart failure by symptomatology. And as a matter of fact, class 4 heart failure patients with, NIHA 4 patients were hardly 1% in the paradigm. So it's something to keep in mind, I mean, when you choose your therapy for those patients. The pioneer heart failure, however, when they looked at patients in the hospital with acute decompensation, they looked at the left ventricular ejection fraction. The anti-quartile range was 18 to 30, which is expected because patients are sicker than the paradigm patients. And the change of ProPNB using Army was a lot better than analog, you know. And what is more important, that there was also a positive effect of the Army regarding mitral regurgitation, which was also presented on follow-up on those patients. So we are not out of options for advanced heart failure before we reach them to device therapy and or heart transplantation. When you look at what happened with Army hospitalized patients, what is really very, very interesting, that some of those patients actually were dropped off the transplant listing because of the benefit they got from Army uses during the hospitalization of heart failure patients. So something to keep in mind. Using ARNI might drop them off the list of heart transplant sometimes. So according to the 2016 European Society Guidelines for Heart Failure Management, when you look at what should I do with heart failure patient with advanced symptomatology, well, I think by definition, a heart failure patient who is not responding to ACE or ARB should be on an ARNI if his blood pressure can tolerate it, and if the GFR is stable too, which is not an easy task sometimes. We have to remember that you can use intravenous iron, as was done in a previous lecture. If the patient still has, in spite of the maximum medical therapy, including beta blockers, and including MRA inhibition, in spite of all the maximum therapy, including ivabradine for patients with a heart rate above 70, in spite of maximum beta blocker tolerable doses, then those patients, don't forget that you have options. You can use digoxin. You can add hydralazine combined with isosorbide dinitrate. Of course, LVAD and or heart transplantation can be offered. The reason I put this here is just we have to make sure that we give our patient the best benefit of what we have medically, especially here in the Middle East. It's not an easy task to get them to have an LVAD or heart transplantation. So how did the guidelines show us what to do with stage D heart failure? Well, when you look at this, the therapy, this is my last slide here so that I don't make it tough for you. The goal is to control symptoms in advanced heart failure patients, improve the quality of life, reduce hospital readmissions, establish patient end-of-life goals, of course. The options are advanced care measures, heart transplant, chronic inotropic therapy can be used, temporary or permanent mechanical assist devices, experimental surgery or drugs. You remember mitaclip, it can work with functional MR for sure. Palliative care and hospice, and ICD deactivation in some patients. Remember that we also have to not undermine the benefit of CRTD in those patients who are actually candidates for it when they have advanced heart failure too. So I think this is my last slide. I want to thank you again. I tried to make it as smooth as possible, considering that we are all running late. Thank you very much.
Thank you, Dr. Hadi. It's a wonderful lecture. He's Amr Zaki, and you concluded, and you were very precise, taking us in the journey of how to manage and how to skip the transplantation. It's excellent lecture as usual, and you summarized the whole story. It was a wonderful end of the day today. We had discussion about the peripartum cardiomyopathy and dealing with patients with pregnant patients with heart failure and how to manage. Then comes the resistance with the potassium binder and how to manage to improve giving the Entresto and all the ACE and ARBs. Then Dr. Khaldoun has taken us to a great journey how to manage in advanced stages the cardiac transplantation, which is not available here in Egypt, and the devices which has been done here in Egypt, but of course because of the economics it's not in a big scale. Then you concluded and you gave us how we can manage and don't stick to the devices, and how we can take our patients into better outcome. So I think now it's fruitful meeting, this one. I've learned a lot from all of you, and it was wonderful. If any question or any... any question from the others?
Maybe we are too late. So everyone, thank you very much, Professor Amr Zaki, for this closing remarks. Professor Hadi, you did a very good job for advanced heart failure definition, criteria, management, everything was covered excellently. Thank you very much for joining us today.
Thank you.
Thank you very much, Professor Khaldoon. Great lecture, as mentioned by Professor Amr, for how to manage case of advanced heart failure, LVAD, transplantation. Very interesting cases that you presented. Thank you very much for your wonderful presentation.
No, it's my pleasure.
I think Dr. Laila is not here. Dr. Hadi from Lebanon.
I am here. Thank you.
Dr. Hadi, thank you very much for your excellent presentation for management of hyperkalemia. And I know that the cost of these drugs are very expensive drugs.
Yes.
So, but it's not available in our country. I don't know. It is available in Kuwait, Jordan, Lebanon. I don't know how the cost of these drugs.
Not in Jordan, Magdi. We don't have them.
Yeah.
Neither in Kuwait, neither in Lebanon. I don't know if Dr. Shab was saying it was available in the Gulf.
Yes, Hadi. He said he thinks it's available, but they don't have a lot of experience using it yet.
It's cheaper to cut down their ACE and MRA. It's $5 rates. Yeah, the only expensive drug that I have access to is for TTR amyloidosis, the Vendimax, the Amidis. I have 2 patients on that. But otherwise, I think we need time for hyperkalemia is a kind of a wishy-washy thing. Yeah.
One thing I did not mention, Magdi, actually, about SGLT2 inhibitors for advanced heart failure. I think it's important also to keep in mind that the patients who were included in DEBA heart failure and in the Emperor reduced, when you look into the details of the NIHA class 2, they were not the sick patients which you and I talk about. So I'm not quite sure. I see Khaldoon nodding, agreeing too, that you can jump to using a SGLT2 inhibitor for a very advanced heart failure patient. You probably have to give them the chance, but I'm saying it, I'm not sure the data is still strong enough for this subgroup of patients.
The majority of patients included...
Of course, personally I've used them, but of course it's not, as you mentioned, it's not on the big scale. So we'll wait for the trials to include them in the very low ejection fraction as 15, for example. So I must thank Dr. Magdi Al-Hamid also, because he gave us all this opportunity all the day to revise all about heart failure. Thank you, Dr. Magdi, very much for including me in this wonderful meeting.
Thank you very much, Professor Amr, for joining us. It's a pleasure.
انا ايمن صالح. انا يعني بشكر دكتور عمرو، بشكر كل المحاضرين والمودريتورز من كل الدول. يعني سعدنا بوجودكم بعلمكم بالتعليقات. طبعا التوقيت في القاهره دلوقتي 11:30 بالليل، فيعني سواري سيشن 1:30 في الخليج.
احنا بعد نص الليل دلوقتي.
فيعني
كويت
شويه ونطلع على السحور يعني. فبنشكركم ونحب نشوفكم في القاهره ان شاء الله دايما معانا. وبشكر كل الحضور الموجودين معانا في القاعه في هذا الوقت المتاخر. شكرا جزيلا لكم.
شكرا.
Thank you very much. Thank you.